All right, everybody, welcome back to our chapter discussing pain and pain management. This is chapter 4 for our course PTA 103, Techniques or Physical Agents and Modalities. So it's really important that we understand some of the kind of basic concepts of pain and how we manage pain. So we're going to discuss a little bit more about that over these next few slides here. So some of the objectives for this lecture here that we're describing. We're going to look at different mechanisms of tissue injury and repair, and we're going to get more detailed in chapter 3, looking at actual tissue injury and what's happening physiologically whenever we do have some form of injury and the different types of repairs that the body goes through. We're going to look at identifying normal and abnormal changes in the integumentary system. Again, probably something we're going to do more in the lab setting. Defining and comparing different types of pain, including acute, chronic, and referred type pains. So we'll discuss those in a little greater detail. Describing the role of analgesic and anti-inflammatory medications. This is something that a lot of students struggle with, is understanding the medications, kind of their role that they play in pain management, and then also maybe looking at some of the adverse reactions to these medications. So those are all going to be important. We'll hit on those in just a little bit. Identify effects of physical agents on pain relief and functional activities. And then the last one here, demonstrate competency in administering standardized questionnaires or pain assessment scales during interventions during a mock scenario. So again, we're going to look at that more in the lab setting, but we are going to discuss some of those different ways that you can measure a patient's pain during the session. So what is pain? Pain is the most common reason people seek medical attention. In the US, chronic pain is more prevalent and more expensive to care for than diabetes, cardiovascular disease, and cancer combined. So when we are licensed or out in the field, even as a student, just entering into your clinical rotations, you're going to have a lot of patients that are coming in to see you just to help manage their pain. Not necessarily involved with some kind of surgical procedure or acute injury, but all of that is going to be encompassed in what you're going to see for your patients. They're going to have pain. It's just how are we going to treat that pain? How are we going to monitor it? How are we going to help our patients improve based on what they're presenting with in the clinical setting? So some of the terminology that you need to be familiar with for this chapter includes nociception, so the neural process of encoding noxious stimuli. And we're going to describe noxious stimuli here in a second. But important to kind of understand what nociception really means, and that's the sensory process through which the nervous system detects and transmits signals about potentially harmful or damaging stimuli, such as noxious stimulus. But examples would be extreme heat, cold, pressure, different types of chemicals that you may come in contact with. And nociception is really the physiological mechanism behind the sensation of pain. But we're going to talk about other things that may also impact kind of that perception of pain in just a second. So that moves us on to noxious stimuli here. You definitely need to know this term. This is stimulus that is damaging or threatens damage to normal tissue. So I'm sure you can think of some of the types of stimuli that would be damaging, like I just mentioned: extreme heat, extreme cold, extreme pressures, but cuts, abrasions, things along those lines would be considered noxious stimuli. We're also going to talk about non-noxious stimuli, which is sensory input to the body that is not typically perceived as damaging or threatening to the tissues. So really important that we know the difference between what noxious stimulus is and what non-noxious stimulus is. Then we also have the term neuropathy. This is a disturbance of function or pathological change in the nerve. I'm sure that you've all heard this term before this lecture, but we think about diabetic neuropathy. There's some kind of disturbance or pathological change in the nerve that is limiting the patient's ability to perceive some kind of sensation. And a lot of the times for our patients that do have diabetic neuropathy, they're going to be numb to this kind of noxious stimulus. So it's not uncommon for a patient that comes in with diabetic neuropathy to have sores on their feet. Maybe they stepped on a tack or something along those lines and they never felt it. And that's really important for us to identify with our patients to limit further damage to the area, infection, things along those lines. Last term on this page here is nociplasticity. This is when the nervous system has the ability, and nervous system and or immune system has the ability to undergo functional or structural changes that really amplify nociceptive processing in the absence or a disease or lesion. So we'll hear terms like peripheral sensitization, central sensitization later on in this lecture, and it's referring to this kind of nociplasticity, this functional or structural change. The word that you're looking for is that amplification. It's amplifying the nociceptive processing, so they're experiencing more pain because of that. This is a nice little GIF that I put up here, which is just looking at some type of neuropathy. So this is a herniated disc that we're looking at here. You can see that this herniation is bulging and you can see it compressing onto either the spinal cord or this spinal nerve root, right where it exits that intervertebral foramen. So if we have compression of that area, we're probably going to see something as far as pain distally to that area wherever this nerve innervates further down the chain. So really common for sciatic nerve pain, down the front of the thigh, back side of the leg as well. So this is something that could lead to what we were just talking about, a neuropathy. So let's talk a little bit about this nociceptive system. So when we think of the nociceptive system, it's important to understand that it's made up of peripheral and central afferent neurons. So peripheral nervous system is relating to anything outside of that spinal cord region, outside of the brain. Central nervous system, again, would be more referring to spinal cord itself and injuries maybe possibly to that brain. So it's important to know that the afferent neurons are responsible for detecting this noxious stimulus. So again, something like extreme heat, extreme cold, pressure, a cut, abrasion, something along those lines. The afferent neurons are going to be the first ones to respond and send that signal to our spinal cord, and then from our spinal cord all the way up to our brain for processing and how we're really perceiving that pain. These can lead to action potentials for the efferent neurons, and we're going to see that here in just one second. But again, we're thinking of this is all information that is basically, it's an input to the brain. It's an input saying you need to react some type of way based on what your body is experiencing. Is it a noxious stimulus? Is it not? If it's noxious, then we need to have some type of motor response to get us away from that potentially harmful stimulus. So if you look at the image below, you can kind of see where in this little pink area here, it shows the receptors. Those are where we have our sensory receptors in the peripheral nervous system. We get this afferent input, or this transmission, along what we call this dorsal root here. So we're going to talk about different spinal tracts as well. But we're going to get all of that sensory information through this dorsal root. It gets to a second order neuron, a third order neuron in the spinal cord and in the brain. It gets shot up, processed in the thalamus, basically the relay station for the brain. And then from the thalamus, it gets sent to different areas of the cerebral cortex. You can also see here that on the bottom side, or this kind of purple or bluish box at the bottom, this is where we get like a motor response essentially from the input that we're perceiving. So we have our sensory receptors transmitting that type of input through those afferent neurons. It gets sent through that dorsal root. On the posterior side, that gets sent up to the thalamus. Once the thalamus processes it and sends it to the other sections of the brain, then we get some kind of efferent response. So it'll be down the system, back out through this anterior side, and that's where we get these afferent neurons that stimulate muscle contraction, different glands, and those types of things. So we're going to talk about this more in your A&P2 class as far as the anatomy and physiology goes there. And you'll probably see this a little bit more in your pathology class as well. But just important to kind of note some of these really basic concepts where this afferent or sensory information is being processed, and then the response through those efferent neurons. Again, here's another little slide that details that in a little bit more. So if you look at the top, the afferent neurons, what is their role? What is their responsibility? They carry sensory information from those receptors in the skin, in that peripheral nervous system, or other organs, and they send that information to the central nervous system. And then when you look at the efferent neurons, these carry motor information from the brain to the peripheral nervous system. So you will have some type of input into the system via the afferent neurons, and then you have an output as well through those efferent neurons. So kind of the difference between an input, sensory information, output via contraction of skeletal muscle in the peripheral nervous system. So when we look at, again, just continuing along this lines of the nociceptive system, those primary afferent neurons, the ones that carry information, innervate these mechano, chemo, thermosensitive nerve endings. So there's a lot of different input that you may experience or your patients may experience that get transmitted through those afferent neurons. It can be mechanical pressure, such as your touch, if you're doing soft tissue mobilization. It can be some type of chemical response or a thermosensitive nerve ending. So specifically for our modality section, right, we're going to talk about soft tissue mobilization and how that will manage pain. It will affect tone. And then we're also obviously going to look at applying a hot pack, applying a cold pack. All of that information is processed through those afferent neurons at the very beginning of that chain of transmission. That's the input again. If we do have something like this peripheral sensitization, that can lead to hyperalgesia. So what does that mean whenever we have peripheral sensitization? It means that pain receptors in the peripheral nervous system become more sensitive or possibly more responsive to stimulus or any type of stimulus due to inflammation or tissue damage. So there could be that structural change, that functional change that leads to hyperalgesia. And what we mean by hyperalgesia is essentially that your patient is going to experience an amplification or increased pain for some type of stimulus that is already noxious. So I like to use this example that we thought of in our class. Let's say that, just as an example, you're going to go get a tattoo, right? A tattoo hurts. It's not the most pleasant stimulus. It is a little bit painful, but typically people can kind of manage that pain, right? They kind of manage it in their own way. They get used to it, whatever it is. But for somebody who, and that's a noxious stimulus, like receiving a tattoo would be a noxious stimulus. It could be threatening to the tissue. You're basically getting scratched, right? That's what it feels like with a really sharp needle. For somebody who has hyperalgesia, it's a noxious stimulus, right? You're getting punctured with that needle over and over again. For the person that experiences hyperalgesia, they may experience that as, you know, it may feel like 10 times more sensitive to them, essentially. So maybe your person who is experiencing hyperalgesia wouldn't be able to go through with a tattoo. But the thing that you need to think of for hyperalgesia, you have a noxious stimulus, but the person perceives it as even more threatening than it truly is. So hyperalgesia, important to know that term. We're going to look at another one here in just a little bit that is similar, but there is a key difference to that. So I'll let you know. I really do want you all to focus on learning these different nerve fibers and the types of transmission, or at the speed of the transmission and the type of pain they are transmitting to the central nervous system. So we're going to start at the top. We're going to look at these C fibers here. These are small in diameter. They're unmyelinated. So what it means to be unmyelinated is that process of getting from your peripheral nervous system to the central nervous system is going to be slower. Myelin sheaths help with that, increase the speed transmission. So if these C fibers are not myelinated, then it's going to be a slower transmission time. The pain that you're going to feel from these C fibers is usually dull, long-lasting, and aching. That's how you would describe the pain that you're experiencing when these C fibers are being stimulated. So that's important to note. Then we move on to the A delta fibers. These are small in diameter, but they are myelinated. So again, we're thinking of the myelin sheath that surrounds the nerve is going to either increase or decrease the speed of that transmission. If it's unmyelinated, again, it's going to be a slower transmission speed. But the A delta fibers are myelinated, so they're going to be this pain that you're experiencing is going to be processed faster. And the pain that you're experiencing from these A delta fibers are typically sharp and kind of stabbing or like a pinprick sensation. So we performed our sensory test. The patient was overreactive to something that is maybe sharp in nature, the pinprick sensation. Maybe we're thinking that there is something like that peripheral sensitization or leading to that hyperalgesia. But the pain is sharp for A delta fibers. Okay. Then we get onto the A beta fibers. Out of all three of these, the A beta fibers are the only fibers that are not transmitting what we call noxious stimulus. So this is why it's important to understand those terms at the beginning of the lecture. C fibers, A delta fibers are both transmitting noxious stimulus. Okay, the beta fibers are really there to transmit sensations such as vibration, stretching of the skin, or any type of pressure that is not going to be deemed as damaging to the tissue. These fibers are also large in diameter and they're myelinated, so again the transmission speed is going to be very fast for these. We're going to talk a little bit more about these A beta fibers when we start discussing the gate theory of pain control. So really important to note that those first two, the C fibers and the delta fibers, are transmitting noxious stimulus to the system, and the beta fibers are transmitting something that is non-noxious. Okay, and that's going to be again really important when we start looking at the gate theory of pain control. So maybe star this slide, come back to it because we're definitely going to test on these different fiber types. So here's another little diagram that I put up for you here. If we're reading all the way from the left-hand side to the right, we can see that those A delta fibers are sitting right on top, and that's some kind of noxious mechanical stimulus that is being transmitted, and you can see that with like a little sharp tack, I believe is what that's supposed to represent. Then we go the one right below, non-noxious mechanical stimulus. So maybe stroking your arm with a feather, it's not going to be threatening to you. Your body doesn't perceive that as a threat. So you can kind of see the differences between what a noxious stimulus would be, stepping on a tack, some kind of mechanical pressure that's sharp, versus the non-noxious mechanical stimulus, the light touch sensation that we perform in lab, or stroking the skin with a feather or something very light. All of that non-noxious stimulus is going to be transmitted through the beta fibers. Then we get down to the very bottom, which is the C fibers. We have a noxious heat or a chemical stimulus. So you see the little fire image or symbol there, and also a chili. So the chili is really what we're thinking of for whenever we apply like a topical cream with capsaicin in it, icy hot, Tiger Balm, those kind of things have a lot of what we call capsaicin. That gives us that burning stimulus. So you can kind of see or start to paint a picture of what those stimuli really look like and how they travel through those different nerve fibers. If you go over to the right-hand side a little bit further, you can see we talked about those primary afferent neurons, the ones that are transmitting sensory to the central nervous system. They all get processed and sent through that dorsal root ganglion here. So you can see They all end up kind of in the same spot. And then just depending on what tract it goes through, we're going to start talking about those in a little bit more detail here in just 1 second. They get sent up through the spinal cord to the thalamus, to the cerebral cortex, and then that efferent system starts to play out with a motor response. Okay, so we'll talk about the different tracts here in 1 second whenever we start looking a little bit more detailed into those. So then the next slide talks about peripheral nerves. What is a peripheral nerve? Well, it's a nerve that extends outside of the central nervous system. It connects the CNS to the limbs, the organs, and the skin. So again, we're thinking the central nervous system is the brain and the spinal cord. And then once those nerve roots leave the intervertebral foramen and they go out and they start to innervate, your fingertips, things like that, that's what we're talking about with peripheral nerves. Those are the ones that you all learned about in Anatomy and Physiology 1. What nerve innervates the gastroc and the soleus, right? Tibial nerve. So that is a peripheral nerve, okay? We also have these different descriptors of different pain from these peripheral nerves. So we have what we call nerve trunk pain. This is typically experienced as deep aching, and it could be due to irritation of the nerve sheaths. There also could be inflammation present or some type of mechanical pressure on those larger nerves. So when you go back to the very beginning of this PowerPoint, I showed you the herniation and the disc, right? That herniation can cause mechanical pressure on those larger nerves as they exit that intervertebral foramen, causing what we may experience as nerve trunk pain, deep aching pain. Then we also have what we call dysesthetic pain. You're going to need to know the difference between these two. This pain is typically experienced as burning, tingling pain, electrical pain, and when we have that type of pain transmission, we're thinking that there is damage to some of those neuronal fibers or the nerve is regenerating. So maybe there was injury to that nerve in the past and it's regenerating, it's starting to sprout again, those little axons. We're going to experience burning, tingling, maybe electrical-like type pain there. This is a lot of what your patients with diabetic neuropathy are going to experience because there is actual damage to the nerves, and possibly another diagnosis that your patient may have, they may experience this type of pain would be with MS. So again, you'll learn about MS a little bit more when we get into our fundamentals of disease course, but you'll notice there are changes happening whenever somebody is diagnosed with MS, especially to the myelin sheath. So if there's damage to the nerve or the nerve is regenerating, again, you're going to experience a different type of sensation, burning, tingling, electrical type pain. Compare that to nerve trunk pain, which is deep aching pain. Okay, so know the difference between those two types of pain, especially as we get into some of our case scenarios and for our exam material. You'll need to know the difference between nerve trunk pain and dysesthetic pain. Yeah. So on to the next slide here. Now we're looking at this dorsal horn. We're not going to get too deep into this because you are going to cover this in Anatomy and Physiology 2. So you'll learn a little bit more about this, the anatomy of the nervous system in just a few weeks here. But terms that you will hear in the future include these first, second, and third order neurons. For my course in particular, we're not going to get too deep into this, but we do want to kind of point out this inhibitory neuron here because that's what is going to really help us and help our patients manage their pain via this gait control theory or this gait theory of pain control. So what does that really mean? I have this linked here, so you can click on that from your actual lecture handouts. It's a nice little video that kind of discusses the gait theory of pain control and how it really functions. But what we really need to know kind of in an easier to understand model is whenever a patient is experiencing pain, let's say in their low back, they may be getting this sharp stabbing pain, electric-like type pain from this dysesthetic pain. There's there's actual damage to the nervous system tissue, we can try to gate that pain, or essentially get rid of that pain for a short period of time by introducing some form of non-noxious or non-painful stimulus to the area. So what does that look like? Let's say, we're going to get into our E-stim chapter in a few weeks. One of the things that we do as PTAs pretty often is we will apply IFC to an area on the low back. We'll apply a TENS unit. And what we're doing with that is we're introducing a non-painful or a non-noxious stimulus to the area that basically allows this inhibitory neuron to stop the transmission of that A delta pain from getting to the thalamus, from getting to the brain. So your brain is not going to perceive that threatening stimulus as long as we have that E-stim unit on, as long as there's that non-noxious stimulus which is constant. The only bad thing about that is that that response typically only lasts as long as that E-stim unit is on. So as soon as you take it off, your patient may experience, some residual effects, decreased pain for the short term afterwards, but it's not going to be an overall fix to the system. They're going to have that pain come back. So it's really good in the short term to gate that pain and close off that chain of transmission to the thalamus and the brain, but it's not a long-lasting option for your patients. We can also have central sensitization. So we talked about peripheral sensitization earlier in the lecture. We can have the same type of thing happen in the central nervous system. So central sensitization, the CNS becomes more sensitive to stimuli after repeated or intense pain signals. So very similar to what we talked about with peripheral sensitization. It's just, where is that change happening? Okay, which part of the system is more sensitive now? Is it the peripheral nervous system or is it the central nervous system? And remember, both of those terms are going to fall under kind of that nociplasticity term that we described at the very beginning. Okay, so I just wanted to bring this up here because this is where I'm going to introduce the different tracks at which these pain transmissions go through. So we can see this here, this little image that we have. We have our source of pain, either through the C fibers or the A delta fibers. Again, you can kind of see some of the characteristics. The C fibers, unmyelinated, slow in transmission, typically that dull aching or chronic pain that your patients will experience, compared to the delta fibers, which is myelinated, so it's going to be a fast transmission time, and you're going to get that acute pain, so like stabbing pain, right? Very sharp pain. They both get processed through this posterior side here in the dorsal root ganglion. And then anytime you see these little breaks here, those are different neurons, so first, second order neurons. And you can see all the way on the right-hand side, pain is transmitted through what we call the spinothalamic tract. So you can see that there, okay? So it crosses the spinal cord and gets sent up through the spinothalamic pain, brainstem, all the way up to the thalamus to be processed in different areas of the brain, the cerebral cortex. Whenever we see the A beta fibers, I know it's not on this, but if we see these beta fibers, they have this same exact pathway until they get here, and then they get shot up through a different tract to the brain. So we can see that the C fibers and the delta fibers come all the way through here, and they come all the way through here, through the spinothalamic tract, okay? But that's only for actual pain stimuli, okay? Noxious stimulus. Whenever the beta fibers send information, they get sent up through a different tract to the thalamus, to the brain, to the cerebral cortex, okay? So those ones go through the DCML, dorsal column, medial lemniscal pathway. So we're going to get this non-noxious stimulus from our beta fibers, like a light touch, like the sensation you would experience during, E-stim. It's going to travel through this dorsal column medial lemniscal pathway. Anything that's related to pain and noxious stimulus is going to go all the way over. It's going to cross through that spinal cord section, and it's going to be sent up through the spinothalamic tract. So again, you're going to talk more about this in A&P2, but I just want you to know that pain, temperature, all those different types of noxious stimulus get processed in the peripheral nervous system and sent to the spinothalamic tract, where it gets shot up to the brain, the thalamus, for further processing. I want you to understand that the beta fibers and the sensation that they transmit get sent up through a different tract, okay, dorsal column medial lemniscal. So again, dorsal column, medial lemniscal pathway, non-noxious stimulus. Input from the C fibers, input from the delta fibers, noxious stimulus sent up through the spinothalamic tract. As long as you know that for now, I will be very happy. So please come see me or ask me questions if you have any further thoughts on that. Okay. We can kind of see in this image here, this inhibitory neuron that I spoke of earlier. So this is really what's responsible for that gate theory of pain control. Again, on the top, you can see that we have this little purple pathway here, so A delta and C fibers, part of the nociceptive system, right? That is going to process noxious stimulus. Bam, it gets to this second order neuron, and then it gets sent up to the thalamus. So what happens during the gate theory of pain control is we are going to try to stimulate these A beta fibers through that non-noxious stimulus, our soft touch, our electrical stimulation, and it's going to really promote this inhibitory neuron to deregulate that system from the nociceptive system, okay? So we're basically closing the gate here. What it's saying is that this inhibitory neuron does not allow this information here from the A delta and C fibers to be sent up this direction. Okay, instead, this inhibitory neuron is going to close that gate, and that process never happens. So we're basically tricking the brain and fooling it to not feel that noxious stimulus during these modalities that we're providing. Again, a short-term relief, but decreasing pain for your patients is going to be important in the short term, and then of course in the long term as well. The next slide that we get to talks about the pain area or the pain matrix. So we're not going to spend too much time on this slide. We're going to kind of skip through this, but here are some of the areas that kind of make up this pain matrix. We have our primary and our secondary somatosensory cortex. These areas process sensory information such as intensity, location, quality of pain. Then we get to our prefrontal cortex. This is the cognitive evaluation and interpretation of the pain. So we're trying to make a decision about this pain. Is it threatening? Is it not? But the portion that I really want you to know for our quizzing and our exam material is that the thalamus is the relay station for the brain. So we're going to underline that one there. Again, we want to know that the thalamus is the relay station. It sends pain signals from the spinal cord to various cortical areas for further processing. So it may come here first, right? It may come to the thalamus first, and then get sent up to this area, get sent to this area for further processing. But the thalamus is where it's the relay station, right? It's going to make a determination on where to send those pain signals. So if you know that, I'll be very happy for the quiz. You can kind of see just a little image here on the right-hand side. Where is the thalamus? If you're kind of wondering what that looks like, here it is right here, kind of right underneath those ventricles. And then again, on the left-hand side, you can see some of these different areas of the cerebral cortex. So where does it send some of this information? It can send it to the primary somatosensory cortex. It can send it to the prefrontal cortex. That's where the pain is going to be processed by the brain itself, okay? And then from there, we make a determination on what to do about that pain. But again, you're going to learn more about this in A&P2. I do want to highlight some of these important factors of the autonomic nervous system. So thinking of maybe some of these efferent systems. So this is a branch of the peripheral nervous system. The two that I really want you to focus on would be the sympathetic nervous system and the parasympathetic nervous system. So sympathetic nervous system means fight or flight. Parasympathetic, rest and digest. So we've talked about this in lecture quite a bit, but as long as you know those two, I'm going to be happy for our quiz purposes. We do want to discuss the different types of pain. So we have what we call acute pain. This is pain typically lasting less than 30 days. Can be caused by post-surgical pain. It could be caused by trauma, like you see in this little image over here. Spraining your ankle, obviously acute type pain. We're going to learn more about how to really manage acute pain with our modalities, but some of the things that you'd want to think of: rest, ice, compression, elevation. I'm pretty sure you've all heard that analogy of rice, okay? So thinking of, combining different modalities, ice and compression with elevation would be a good bet for this type of acute pain. Then we have chronic pain, typically lasting 3 to 6 months. It's a result of persistent nociception, so always having this kind of sensory input which is noxious to the system. It could be a neuropathy, it could be central sensitization. All of those can lead to what we call chronic pain. The thing that we want to think of here, there's definitely modalities that we can utilize. We've talked about the gate theory of pain control. We're going to learn another one when we get closer to our E-stem chapters that discuss more of an opiate release therapy or protocol, and that's going to help with longer lasting pain relief. So you'll probably hear that term in the next few weeks. But the other thing that we want to really do is help promote functionality for our patients. For somebody who's been dealing with pain for 3 to 6 months, there's a good chance that we have some real effect with our sessions on decreasing their pain levels. But I've treated patients that have had pain for 5 years, 10 years, and nothing that we do can really seem to help them get rid of that pain. So we want to educate our patients and really help them be more functional, okay? We're trying to promote that functionality. They may be able to manage their pain using some of these modalities like ice or heat or E-stem, but we want to really make sure that we're educating them on, managing their pain and their expectations for their pain instead of just trying to get that pain level to 0. So some of the things that you might see would be CRPS and phantom limb pain, also osteoarthritis, would be these different types of chronic pain. We're going to also look at these different pain mechanisms. So we have what we call referred pain and neuropathic pain, and then that nociplastic pain. So referred pain is essentially pain that you're experiencing, let's say in your thigh, that is not really originating from that area. So you're feeling pain in your quadriceps, but the injury is really at your low back area. We're getting that nerve root compression via a herniated disc or something like spinal stenosis, and we're experiencing pain further distal to that area where it's actually originating from. So there's a lot of different pain maps out there for referred pain. We'll look at those in later courses when we get to therapeutic exercise, but that's what referred pain is. When we have this neuropathic pain, we're thinking there's maybe a disease of the central nervous system, some type of mechanosensitivity, allodynia, or different temperature changes that they may be experiencing. And I do want to highlight this term here, allodynia, because we talked about hyperalgesia just a little bit ago, and students usually get these ones confused. So we talked about hyperalgesia. Hyperalgesia is the perception, like first of all, you're getting an input that is noxious, like we used our tattoo example, right? That's a noxious stimulus. I don't think anybody would disagree with that, but most people can tolerate it, okay? Hyperalgesia, they're experiencing this heightened perception of what is normally noxious. So you step on a Lego, that's a pretty noxious stimulus. For the person with hyperalgesia, they're going to think they stepped on a thumbtack. It's going to feel more painful than it should. With allodynia, we have a little bit different kind of input. So now let's say you want to draw dermatomes on your arm. So I take my pen and I'm going to be drawing the dermatomes along my arm so that I can learn those different dermatome patterns. That would be considered a non-noxious stimulus for most people, right? Really soft felt tip marker, something along those lines. But for your patient with allodynia, they're going to experience that non-noxious stimulus as noxious stimulus. So maybe we're drawing on our arms with a marker, but to them it feels like they're receiving a tattoo. They have that noxious kind of perception of that pain, okay? So really important to know those two terms and the difference between them. Hyperalgesia, noxious stimulus with a heightened response. Allodynia, non-noxious or non-threatening stimulus that is perceived as noxious or threatening to the tissues, okay? Whenever we're measuring pain, it's important that we do a good job in our subjective section or our interview process. We're trying to do our best to measure their pain intensity, the number at which they're experiencing their pain, so our 0 to 10 scale. But having a good measure of the pain helps with communication between patients and providers. You know, what type of pain are they experiencing? Is it something that's dull and aching, maybe related to nerve trunk pain, or is it that really sharp electric-like burning sensation, which would be more of that dysesthetic pain? That may alter the way that you are treating that patient as far as modalities go, and as far as what interventions you want to choose for that person that day. It also helps us target the treatment area. You know, if you're experiencing referred pain, you know, I have this pain in my thigh, it's been there for a long time, but you do other testing like manual muscle testing, and it's really, you don't see any impairments there. You look at the range of motion of their knee or their hip, and you don't see any impairments, but then you get to the low back area, and you're like, this is probably where this pain is originating from, based on the tests that I've performed, based on your past medical history, you know, maybe even just their posture would kind of point you to that direction. It also really helps to set goals for your patients. So again, not trying to decrease your pain to 0 if they're experiencing something like chronic pain, because maybe that's not possible for this person at this time. But setting goals and expectations for the treatment session, again, really important whenever we're measuring pain for our patients. And then the last thing, probably the most obvious, is that it really helps to monitor the treatment effectiveness. So maybe they came in, you know, initially and they're screaming at you, my pain is 8 out of 10. Just here at rest, we perform our treatments, we perform our modalities. You ask them again, how do you feel now? Is your pain better, worse than it was before when you came in? Well, now it's at a 2 out of 10. So this is manageable. So that really helps us monitor if our treatments are effective or if they're not. If they're not effective, we have to change something, right? We can't just continue down this path that isn't helping our patients decrease their pain levels. Some of the scales that we have used in the past and we've talked about, the visual analog scale, the numerical rating scale, which is probably the most common one that you're going to see in clinic, and the Wong-Baker face scale. So just to kind of review here, visual analog scale, your patient's going to place an X or maybe slide a little ruler thing along the line and shows, how intense their pain is. But the Wong-Baker face scale, again, something that if you're having difficulty communicating with your patient, they're nonverbal or something along those lines, you can use this as well. And then there's also this nice little descriptor here for pain. So there's a lot of different ways that your patients are going to describe their pain. I've heard anything from like a flowing pain to sharp stabbing, electric-like type pain. I've heard all of those before. Exhausting, it's suffocating, it's annoying, it's nauseating. So we want to be as descriptive as we can whenever we're measuring our patients' pain scales. So I'm not saying that you should infer that you're not trying to get them to say one thing or another, but just describe it, right? Describe it as best they can. Is it throbbing? Does it radiate? Does it feel piercing? Those are all really good descriptors because maybe their overall pain scale doesn't show a ton of improvement, but maybe it's less nauseating now. Maybe it's less suffocating. Maybe it just moved to more of like an itching or a tingling sensation. Those are all really good ways that we can monitor the response to the treatment. So get a before for a baseline and make sure that you do an after as well to, again, see if our treatment is effective or not. One of the things that I always tell my students is that when we're going through this modality section, we're learning all these different techniques to help manage pain, but the most important thing that you want to educate your patients on is that pain management should never be completely passive, okay? If we just have our patients come in, put a hot pack on them, put E-stem on them, and then we kick them out the door, we're not doing anything to help promote their functionality. We're not showing them how to be independent and how to manage their own pain away from a clinical setting. So we always want to make sure that we're providing these modalities, providing these therapeutic techniques in a way that doesn't make them 100% reliant on us, because that's not what our role is as a PTA or a PT, right? We want to make sure that our patients are independent, that they are aware of how to manage their pain away from us. So it should never be just a passive thing. Physical agents are great. Pharmacological approaches are also, very useful and helpful, and it's something that you're going to deal with a lot as a student, as a PTA, as a licensed provider. So knowing we're going to look at some of these medications in a second, just being able to kind of use all of these in combination with each other to help manage your patient's pain. So let's talk about these different types of medications here. So I broke this down for you here in these little sections. So we have the very top one, nociceptive pain from tissue damage or inflammation. Here are some of the medications that we use to manage that type of pain. So we have NSAIDs, or non-steroidal anti-inflammatories, such as ibuprofen or naproxen. We have acetaminophen or Tylenol, which is basically just an analgesic and a fever reducer. We have opioids like morphine or oxycodone. Those are all used for that kind of nociceptive pain from tissue damage or inflammation. A little bit different from what we're going to see on this next section here. So for somebody who's dealing with neuropathic pain, maybe from a nerve injury or some kind of dysfunction, they're going to be treated differently in that pharmacological sense. So they may be prescribed antidepressants, they may be prescribed anticonvulsants like gabapentin. That's probably one that you should highlight here, is this gabapentin. Or they may even use something like topical agents, something with lidocaine in it, something with capsaicin in it to help decrease that overall sensation of pain. This is what I really want you to pay attention to, are these adverse reactions to these medications. So when we look at NSAIDs, there are a few things that we need to be mindful of. So some of the adverse reactions that you might see include GI ulcers, increased bleeding, kidney dysfunctions, increased blood pressure, and definitely increased risk of bruising. So what does that mean for us as PTAs? We want to be mindful of any kind of GI discomfort, especially if we're doing any type of if we're increasing abdominal pressure during exercise. So with manual work, with bracing techniques, we want to be really cautious of those for patients who are taking NSAIDs. When we look at acetaminophen or Tylenol, one of the worst adverse reactions that you might see includes liver toxicity. So we want to be aware of signs of jaundice or unusual fatigue. So jaundice, again, yellowing of the skin, some of those mucous membranes like the eyes would be a clear indication that they have some form of liver toxicity happening, or there's something unusual, right, that's happening there. These are all times that you would want, like especially if you notice somebody has jaundice from one session to the other, something you want to relay to your supervising PT and take it up the chain of command there, because that could be something potentially more serious. For opioids, some of the adverse reactions that you'll see include sedation, dizziness, constipation, or even these addictive type tendencies. So you want to monitor as a PTA for signs of dizziness. You want to be really cautious with exercise involving lots of focus and coordination. So could be a fall risk, and that's something that we want to be aware of for sure. Continuing with the adverse reactions, so to antidepressants, drowsiness, dizziness, OH or orthostatic hypotension. So just remember that orthostatic hypotension is something that you're going to see with positional change. So your patient is supine, they go to a sitting position, they start to get really dizzy, uncoordinated again. That's really due to the positional change. So as you change their position from supine to sitting, their blood pressure drops significantly, which would cause this dizziness or this drowsiness. So you really want to be cautious with positional changes. Make sure you have a gait belt, make sure that you're guarding them, make sure that they're not at risk of falling. Okay, and we'll talk about different ways to manage OH later on. For anticonvulsants, again, you can kind of see some of these have very similar adverse reactions, dizziness and ataxia. So when we're thinking of a patient that has gabapentin, gabapentin decreases the speed at which some of those transmissions travel, and we'll talk about the physiology behind that in just a little bit in more courses, but it's going to decrease that conduction speed along those nerves, those peripheral nerves. So if you're asking them to perform really high balance activities and you notice that they're very uncoordinated with that, or gait activities, it's probably because of this adverse reaction to something like gabapentin. So you want to be really cautious with those types of activities with patients who are on those medications. As far as topical agents go, you may see something like skin irritation, maybe a rash, or that typical burning sensation from capsaicin. You just want to make sure to avoid placing heating pads over those topical medications, because that can increase the absorption rate of those different topical agents. So you put a heat pack over somebody that's got Tiger Balm or Bengay on or something like that, and their pain starts to get worse and worse. It's probably because your skin is absorbing more of that medication transdermally. So just avoid placing hot packs on patients that have those topical agents. Okay, so that brings us to the end of Chapter 4, Pain and Pain Management. I hope this was helpful. If you have any questions, feel free to reach out to me directly. But thank you so much, and again, hope it was helpful.